Thanks to those who are joining this morning. We're getting started very shortly. All right, so welcome everyone to Chatbots, board games, and more, using innovative methods to engage men in family health. Next slide. So this webinar is hosted by the USAID-funded Momentum Project, which is a suite of awards working in more than 30 countries to improve the health and well-being of individuals, families, and communities, with the ultimate goal of accelerating the reduction of maternal, newborn, and child death and disability. Today, we will have speakers representing 5 of the centrally managed awards. Could we get the next slide, please? So those 5 awards are Momentum Routine Immunization, Transformation and Equity, Momentum Country and Global Leadership, Momentum Integrated Health Resilience, Momentum Private Healthcare Delivery, Momentum Safe Surgery in Family Planning and Obstetrics, and I am Reshma Naik, Senior Director for Knowledge Management, representing Momentum Knowledge Accelerator, which is known as the Suites Connector. So we are really excited that you've joined us here today. Next slide, please. So before we get started, I have a few quick announcements. First off, please feel free to introduce yourself in the chat. Second, as we proceed, if you have any questions for the panelists, we encourage you to submit them through the Q&A function at the bottom of your screen. Our panelists and their colleagues will be providing written responses to them in that space. And then feel free to use the regular chat space for any general comments or reflections. Next slide, please. During this webinar, you can view the slides in either English or French. At the top middle of your screen, select View Options, and you will see 2 choices to view the slides in either English or French. So please do that now. Next slide, please. We are also offering simultaneous interpretation in English and French. So to choose your language, click on the globe icon at the bottom of your screen. Everyone attending today should select a language to be sure that you hear all presenters. Note that we will be having 1 person presenting in French. An important note is that we do not recommend selecting mute original audio, as you will only hear the interpreted language and may miss out on a panelist speaking. Next slide, please. So these are the same instructions for choosing a language written in French. Lastly, I just want to let you know that this webinar is being recorded. We plan to send out the slides and the recording shortly after the event to all who registered. And now I'd like to introduce you to our esteemed moderator, Peter Weiswa. If you're not already there, Peter, please do come on screen now. Peter is one of the co-chairs of the IGWG, or the Interagency Gender Working Group Male Engagement Task Force. Peter is also an associate professor at Makerere University School of Public Health in Uganda and in the Global Health Division at the Karolinska Institute in Sweden. So thank you for moderating today, Peter, and over to you.
Thank you so much, Reshma, for setting the stage and for introductions. We are here today to discuss Momentum Project's gender transformative approaches and insight based on their experiences in engaging men in various aspects of family health, whether family planning for their partners, immunization for their children, or reproductive health for themselves. While this is not new, it's not a new topic of engaging men in reproductive health and other health promotion and services, it remains very critical. The Interagency Gender Working Group, or Males Engagement Task Force, it has the do's and don'ts for engaging men and boys, and it has this resource which is quite important and is being shared on the screen for people to look at as a key guidance. It reminds us that we should engage men and boys both because of their distinct health needs and vulnerabilities, and because engaging men can benefit everyone, including women and girls. For example, we should recognize and meet men's distinct needs, but also be careful not to engage men at the expense of women. Engaging men and boys encourages us to try to transform harmful gender relations and norms while not overlooking the diversity of men and boys. For reference, we will also add a link to the United States Agency for International Development's 2023 Gender Equality and Women's Empowerment Policy, which provides the vision for USAID's work to advance gender equality and women's empowerment around the world. This might be, so it's quite important that people look at those documents because they are quite good for policy documents. Today, we'll hear from the Momentum projects in engaging men and boys in Mozambique, in Pakistan, South Sudan, and Cote d'Ivoire. We will hear about a first of its kind chat box aiming to destigmatize conversations around family planning, reproductive needs, and contraceptive options. Findings from an evaluation using the most significant change technique to understand how men can be engaged in family planning or reproductive health and in maternal, newborn, and child health services in a way that is responsive to the couple's needs without undermining women's rights and autonomy. We'll also hear insights from working with community health committees, local leaders, and influencers to understand why men are not involved in their family's immunization journey. We'll also do a pre-test. We'll look at a pre-test results of an interactive board game on male engagement that couples can use to learn about child spacing. And finally, we'll get reflections on findings from a recently published global analysis of vasectomy trends. Our plan for this webinar is to start with a short presentation for each of the panelists. So as the panelists are presenting, please feel free to add any questions to the Q&A tab at the bottom of your screen, and any comments and reflections on the chat. We'll try to answer them. After the presentation, we'll have a discussion with the full group to dig in deeper and reflect on the lesson learned from their work. And with that, I'll turn it over to Ayesha, who is the country director of PSI Pakistan and the part of Momentum's private health sector, healthcare delivery, to tell us about the VIA chatbot. Over to you, Ayesha. Ayesha, if you can put on your video and also unmute yourself and make your presentation.
Sorry, can you guys hear me now?
Yes, thank you.
Perfect. Thank you so much for inviting me to this webinar. I'm quite excited to share the learnings that we've had in Pakistan. If you could move on to the next slide, please. So Pakistan is a very unique country where we have seen that the population size of Pakistan and the population growth rate of Pakistan has been far greater than what healthcare professionals would like it to have. Our MCPR amongst married women is stagnant over the last 30 years. It is at 26.9%. Family planning messaging has essentially been targeted towards women. However, we have seen in our country that men, it's a patriarchal society, men play a very important role in the decision-making of what choices should women have when it comes to family planning, contraceptive choices, and etc. However, despite the fact that they have a higher decision-making authority, they do not have any information or right information regarding contraceptives. And since essentially programmatic approaches have not been geared towards them, there remained a huge gap. And there is a huge stigma or rather shyness related to use of family planning, or shame related to use of family planning contraceptives, etc. as well. There are very limited male partners in Pakistan who remain little informed. With these challenges in mind, and knowing fully that there's no change essentially seen in the MCPR growth, we realized that we needed to do something differently over here. And one of the target groups that we wanted to focus on was men, because as I said, they have a higher decision making in family planning choices. However, they don't have the right information, or don't have the sources or channels to get the right information. So with that insight in mind, we saw that as an opportunity, and we launched Pakistan's, first. We took the approach of gender transformative, and launched a gender transformative trainings for those men who are working in the space of family planning, as well as messages around for common man, so that they can understand their role better in family planning. We have also seen that in Pakistan, programming has essentially been very analog. And when I say analog, what I essentially mean is that it has been very traditional way of working that that happens in the development sector. We realized, again, looking at our stagnant MCPR, looking at our stagnant market growth, we realized that if we wanted to reach a huge population of men and we wanted to make a difference, we had to do things differently. And we have to approach men more, faster, and in a way that resonates and it's more convenient to them, so that we could address the shyness element, or the, issues around privacy that they require when it comes to a taboo topic like this. We've also seen that certain provinces within Pakistan, there is higher uh, demand from them in promoting family planning and investing in male engagement, and we took that as an opportunity as well. And we took on the role of using internet, social media, mobile connectivity, which is also again in Pakistan one of the highest connectivity in mobile use in Pakistan, and that too men have more access to mobile phones. We felt that we needed to leverage on these opportunities and cater to men in Pakistan. Next slide, please. With this, as I mentioned, because we knew that we had to do things differently, we introduced our global brand called VIA, which started as a chatbot. It's a first of its kind lifestyle wellness chatbot, which it works on WhatsApp, and it's the first chatbot in Pakistan which caters specifically to men. It addresses what we have essentially done is we did a extensive research, and we identified the different type of men in Pakistan, and we created their personas. Based on those personas, we then created content which was gender transformative, because there is a fine line between giving messaging to men so that they are aware of family planning, they are aware of sexual reproductive health, but at the same time, we don't want to give power into their hands and make them feel that they have full ownership of the decisions that need to be made. We want to encourage couples to make those decisions together. So we launched our chatbot back in September 2022. It caters to men and women both, but essentially targeted towards men. There is a platform, because this is a platform approach, there is a website associated with this as well, and it's still work in progress. We are working on that. We had a performance marketing-based social marketing campaigns. We did those on Facebook and Instagram. We also have YouTube. We also did some conventional below-the-line activities, went to universities, spoke to men, boys, so that we could get them to use this chatbot. So that there is this message that goes out from one man to another man through social media, through our marketing efforts, that there is a private platform available for men where they can seek information. And if they want to seek this information with their partners, with their wives, they can seek the information with them as well. We intend to also incorporate telehealth, telemedicine into this, and e-commerce, essentially because we want to close the loop. And we want to give consumers, men and women, a frictionless journey, so that once we have given them the right information and we have sort of gotten them to gain interest in this space, understand more on family planning, SRH needs from a lifestyle, how it impacts them, how it affects them, get that information. If they want to adopt a family planning method, they can use telemedicine or e-commerce platforms to get the product or service that they require. Now, For e-commerce, we have a very important, one of the important things that we wanted to focus on was that women in Pakistan do not go to pharmacies to buy products, especially when it comes to condoms. Even for men, it's an element of shyness. They don't get to, sort of
Aisha, you should be
go.
summarizing.
Yes. So they don't get to, go and get these products themselves. So we want to give men and women a choice of e-commerce where they can together make a choice of what kind of products do they require. Next slide, please. Here are some of the impact that we have achieved so far with very little marketing that we have done. We have roughly around 38,000 plus new users on the chatbot. These are men. 87% of these users are men. Average age is 28. Average messages you can see over here as well. And what one of the most important thing over here is you will see that it's 48% married users. This has been a very good insight for us because remainder of the men who are using this chatbot are not married, and that's we can easily say that this can be youth who do not have platforms in Pakistan to be able to get this information. 70% of the users are Urdu users, which is also a very great sign for us because we felt that probably, English-speaking people will use the chatbot more or feel more comfortable with it. But 70% of the people who are accessing our chatbot are accessing it in Urdu language, which is a very promising result for us. Next slide, please. Here are just, sort of
Aisha,
summarizing.
we have run out of time, so if you could go over this very
I
fast. Thank you.
Yeah, sure. I think this is, I'm already done. As I've already mentioned, it's an omni-channel bilingual chatbot. It has English, Urdu, both. We can see that, majority of the people are using the chatbot in Urdu language. Most important topics that are being talked about are sexual health, related to sexual health, family planning, and myths related. And average age is 28 to 29 years old. Next slide, please. And I think I am done with. Yeah, thank you.
Thank you so much, Aisha, for telling us about the chatbot and how men have used it in Pakistan. Now we'll be hearing to invite Rosalind Ebua, who is the gender advisor for Momentum.
Merci beaucoup. Mais je pense que la
Thank you very much. The presentation
Côte d'Ivoire
that's
to make her
on the
presentation,
screen.
and you have 5 minutes. Rosalind?
Allô? Oui, j'ai la version
Yes, I see the English version of the presentation. Could I have the French version posted, please?
I hope you selected the French slides, Rosalind.
Okay.
If you could go at the top and select English, French slides.
Merci beaucoup. Ma
Thank you.
présentation porte sur le thème
My presentation is about engaging men while strengthening women's autonomy, using the most significant change to understand male engagement in Côte d'Ivoire and Togo. Okay, MCGL overall has a learning question about the involvement of men. And on this global learning question, Togo and Côte d'Ivoire specifically created a more specific question. How can males be involved in community-based couple communications in a way that promotes positive FP maternal health outcomes without compromising women's rights and autonomy? Now, to answer this learning question, interventions were put in place in both countries. Specifically in Côte d'Ivoire, we set set up a group communication intervention. And the tool that we used was an adaptation of program P that was developed by Equimundo. Now, how did we assess the results from this intervention? For the evaluation of our couple communication intervention, we used a methodology that was qualitative about adaptive learning called the most significant change. So the methodology meant that we had to create one single question that is shown in the slide. In your opinion, what is the most important change that has occurred in your community regarding the roles of women and men in FPRH since the couple's activities began? And based on this question, activities were led in the various areas with the beneficiaries and the key actors in the implementation for year one of the project in order to collect data on what changes had taken place. And what were the results of this study? As you can see in the first table, this table shows the various significant change stories we collected in the field. They're classified by area and by gender. Blue is men and women are in green. And the various areas of change concerned men, the role of men in health, harmony in the household. We saw changes in the attitudes towards the use of family planning and also changes in decision making. And this shows the stories that were selected by topic. I'll give you an example of a significant change story that was given to us by a participant. This is about the role of men in the household. When we started work, I could see that my husband had changed. He helped me to work. In the past few days, I've been sick, and when we go to the field, it's him who cuts the wood. He takes the yams and banana bunches on his bike to send to the village. I've been sick for a long time, and my husband wouldn't give me any money to go to the hospital. But the day before yesterday, he gave me money and accompanied me to the hospital for treatment. So these are some of the words that we heard from one participant during the collection of data. And this helped us to respond to our learning question. This study made it possible for us to note several areas of change in the field, and one of them was FP. And the study showed a positive attitude towards FP among some couples, and an increase in the number of couples that used family planning. Now, in terms of the role in the household and their attitude towards health, the study showed greater involvement of men in daily tasks, in field work, and in the health of their wives and children. And this is due to the improvement of the collaboration between the partners. We also heard enough stories about changes that showed improved communication among couples for some of the couples that participated in this work. And this improved communication improved the harmony within the household. There was a reduction in violence from intimate partners. We also noted, but there weren't enough changes. We saw some improvement in the participation of women in decision-making within certain households. Another change that we saw is the acceptance of a woman's wishes by the husband. Husbands having better understood the needs of their wives through this, especially their health needs. They have become more aware of the challenges that face women, especially in terms of household tasks and field work tasks. And so they have decided, they have wished to help their wives. Now, in terms of this change, we didn't see enough change in terms of the decision-making power. There wasn't really any change in that. And here are the results from our work in Côte d'Ivoire. Thank you.
Thank you so much for that, Rosalind. And I would like to remind the audience to add any questions to the Q&A or comments and any reflections from the presentation so far. We shall respond to them. Before we hear from our next presenter, we are going to make a quick poll, and where we invite participants to make some responses in the chat. A poll on this. In my setting, I have seen programs designed and implemented in ways that engage men without limiting or compromising women's autonomy. Could you answer this poll based on your experience? I'll give you about 30 seconds. Okay, let's see the results. It seems that most of you, that is about almost 45%, somewhat agree with this, and another good percentage of 21% agree. So, which is in general a good thing. Thank you so much. We can close the poll. Now, so we're going to get our next presenter. We'll now hear from Neide, who is the National Social and Behavior Change Communication Advisor for Mozambique on the Momentum Routine Immunization Transformation and Equity Project. Go ahead, Neide.
Thank you. Good afternoon, everyone. I am Neide Gazella, the National Social and Behavior Change Advisor for Mozambique. The Momentum Routine Immunization Transformation and Equity Project applies its best practices and explores innovations to address entrenched obstacles in immunization and increase equitable immunization coverage. We envision a world in which people are, in which everyone is eligible for immunization from infancy throughout life course, and particularly underserved and marginalized and vulnerable populations. Next slide, please. Yes, thank you. Millions of children continue to miss routine vaccination each year. Gender and norms, sorry, apologies. Gender roles and norms detect that mothers alone are sole takers, are sole caretakers of the children. We in Mozambique are working on male involvement to improve and sustain coverage. We have seen that the lack of male involvement contributes to reduced immunization uptake. It also increases dropout in vaccination and also in commencement and completion of the routine vaccination schedule for the child. We've noted that demand generation interventions are traditionally meant for women, resulting in men feeling unwelcome or uncomfortable at child services. We do see that at some point men feel that they do not have much to do when it comes to the child immunization, but mostly it's because they do not know what they should do. They are not aware of what should be done. Lack of laws and policies as well, data training on gender issues as well in the health sector is also one of the issues that we've seen in male involvement in Mozambique. Next slide, please. Gender-related drivers and domain affecting health. Here we have this image that is taken from the Momentum brief on a gendered approach. we have seen that access to assets is one that we have seen. Practice and participation as well, beliefs and perceptions, institutions and laws that look at that influence health, often established systems in which restrict women's and men's access to quality health services and information. Next slide, please. Here we have put the insights on the provinces where we are working in Mozambique, which is the northern part of Mozambique. We have here Nampula and Zambezia provinces, where our focus is in Mozambique. Male involvement in these provinces is considered an action where men take the child to the health facility to be vaccinated. When we look at it, we do see that men are eager to do this. And they're eager to take their child to the vaccination post, to the health facilities, but as well, it is not in line with their social norms, especially in the northern part of Mozambique, in Nampula province, where we have a lot of, the province is mostly Muslim people. So this would not be a social norm for them to take the child to the health facility to vaccinate. Specifically, if we don't have, especially if we don't have spaces for men to be in the health facilities. In general, limited or no information on immunization also makes the men not take the child to the health facility. If the father or the man is not informed about the vaccination calendar, he is not aware of what the do's and don'ts for men to be involved in the vaccination of the child, he will not take the child for vaccination. Next slide, please. Yes, the messages we have used in the work we are doing in the northern part of Mozambique on male involvement include the importance of men providing for women to take the child to the health facilities. And here we are addressing the issue on access. As well, we are looking at we share messages on the men being able to accompany the mother to the health facilities and walk with them in the long distances that they have to walk when they're taking the child to the health facilities. Here we are also addressing the issue on access. Apart from that, we are also looking at, we also expect men, if they cannot go with the mothers to the health facilities, they can stay at home and do the other chores that the other chores that the mother normally do when it comes to the household chores for the mother to be able to take the child to the vaccination. This specifically addresses the issue of freeing up of practices and participation and use of time when it comes to women, because we know that women are the ones who have the most a lot to do in the household. They cover most of the house chores, and if they are freed up to take the child to the hospital when the father stays at home to do other chores, then we see this as we are sharing this information for the men to be able to understand. We also discussed the importance of vaccination and vaccination calendar itself. Our experiences showed that men are not aware of, they are not aware of the vaccination calendar. So our work, we make sure that we are sharing information on the vaccine the child should get type of vaccine. And this is being shared through the community working groups that we have, the community health actors, and this, and so on. Next slide, please. Thank you. The project in Mozambique, we are prioritizing male involvement in both provinces, as mentioned. We can see some images here where we have men at health facilities taking their child for vaccination. We are expecting this, we do expect this, but this is not all that we want from men, as mentioned in the previous, that there is a lot more that we getting men to do or to get involved in the immunization of the child. We are working with community health workers to guarantee that demand generation activity for immunization services involve men without at all diminishing the women's agency or autonomy. The project is also working to address behaviors and beliefs that dictate that women should be solely responsible for child immunization. Next slide, please, if we do have. Thank you.
All right, thank you so much for that. We will now hear from Kenya, who is a social and behavior change advisor on Momentum Integrated Health Resilience Project. Over to you, Kenya.
Thank you, Peter, for having me here. Okay, just to be able to let the participants know that Momentum Integrated Health Resilience in South Sudan, since the start of, in the beginning of its project, conducted social norms assessment. And in this assessment, there were findings. And some of the findings are what we have developed the board game on. Next slide, please. Yes. So from the findings of the social norms assessment, we were able to understand that men hold disproportionate kind of power, and they hold the decision-making positions in the communities and also have more access to resources. And this means that they have a significant influence on women and then the girls. Again, from the social norms assessment, the findings were able to inform us that men and boys are not aware of the benefits of antenatal care as well as the postnatal care. The other thing is that the social number assessment was able to inform us that, okay, there are taboos that surrounds first menstruation of the girls, especially in relation to the men understanding about menstruation. Again, the concept of family planning is something that does not resonate well with the people in South Sudan. Next slide, please. Okay. In relation to how we use male engagement in addressing these challenges, male engagement activities were chosen based on the social norm assessment that was conducted. And we use what we call the partnership defined quality as our social accountability strategy in the country. And then what we use again is that we use what we call a community action cycle as a gender transformative approach that brings gender lens into sexual reproductive health. So it's important to recognize that we have a multi-channel and multi-level approach to male engagement. And today, as we talk about the male engagement board game, this is what we'll be discussing. So the board game is an interactive kind of board game that fosters discussion between men and women, especially on the gender norms. The board game again highlights the benefits of male engagement in family planning and reproductive child health, especially maternal and child health, or ANC. The board game again also allows participants who are playing this game to be able to understand the consequences of not involving men and boys in decision making. Next slide. The types of messages that we have in the board game includes, for example, male partners may not understand the complications that pregnancy may bring, and they may not be able to support their women if complications arise. Again, the board game discusses issues related to resilience. And on resilience, we are focusing on issues that compares a family with a big number of populations, for example, many children, and those ones which are having few number of children. Of course, if it comes to shocks and stresses, it will be very difficult to manage, especially those families with big number of children. Again, women may not be able to understand, women may not be able to attend all ANC visits without the support of their men. And these are some of the messages we have in these board games. Next slide, please. Okay, on the benefits of male engagement in South Sudan. So based on the social norms assessment that was conducted by Momentum initially, we developed a platform called Sawa Lebad, or Together for Each Other. And this is basically to be able to create a platform where men and women can easily be able to discuss and also be able to compromise. As I mentioned earlier on, the social norm assessment was able to mention to us that men hold most of the decisions at the family level. So this Sawa Lebad is a call for unity. It's a call for unity that will enable the man to understand the importance of family planning in relations to the families. Again, the concept, which is Sawa Lebad, provides a culturally appropriate framework to achieve gender equity, balance inequitable power dynamics, and ensures that the sustainability of health behaviors. So here are some of the benefits that we realize from the male engagement activities that we do here in South Sudan. For example, in some locations where we are currently implementing, for example, in Magwi County. In Magwi County, we've seen an increased trend in the service uptake, for example, family planning. Again, we now see men escorting their women to ANC services, and that's a very good sign. Again, there's reduced rates of violence. One of the chiefs in some of the locations where we are implementing mentioned that, for example, in 1 month, they could solve like 10 cases. But nowadays, as we introduce the male engagement board game, they are now receiving at least like 2 to 3 in a month, which shows us that men are now understanding the importance of the importance of gender. So there's also increased social cohesion, for example, as a result of the Sawa Lebad. That shows that men and people are now understanding the importance of working in unity. Next slide, please. Okay, on the outcomes of male engagement activities in South Sudan, we also got information from some of the mentors at the family planning units, mentioning that they are able to see men coming for consultations with their women. And previously, this is what was not happening. And I think this is a very good trend that men are now understanding the importance of family planning. So, for example,
you should be summarizing.
All right, thank you. Thank you. Okay, again in Juba, we are happy to mention that we have volunteers whom we call the male champions. These male champions, as a result of the male engagement board game, came out openly and willing to be able to share with their peers at the community level the importance of family planning and also working in partnership with their women. So what I would say at this juncture is that male engagement is an important strategy, and it's, however, a complex kind of an activity which requires your time. So by involving men, we'll be able to create, let me say, a very healthy family and also a healthy community. Thank you.
Thank you so much, Kenny, for those examples from South Sudan. Now, before we hear from the last presenter, I want participants to reflect on what have we learned this far. In a few words, if every participant could type in the chat to describe something that has resonated from or been surprising about the presentations. So if you can go, we have about 15, 20 seconds to type. I would like to see the chats in the chat. If you could write what has been what has resonated with you or what has surprised you. I've seen one or two. So if we can have more people write something, what has resonated with you? What has surprised you? Some of the answers coming, male involvement is very crucial. And male are willing to participate through, although they are not targeted, so we need to target them. And the facilitating couple communication is key first step. So there are several which have come. Please keep them coming and let participants be reading them. Now we are going to our next presenter, who is going to be Roy. Roy, if you could go with your presentation. Thank you.
Thank you, Peter. And hello, everyone. Maybe I could have the next slide. I'm going to give a very brief overview of highlights of a study we conducted of vasectomy use and trends in its use and prevalence worldwide and in low and middle income countries. This paper appeared in Global Health Science and Practice a few months ago. We looked at vasectomy use in 95 countries that constitute around 90% of the world's population, 84 low and middle income countries in all the regions, and the only 11 countries, higher income countries, that have a vasectomy prevalence above 1%. We compared the use of vasectomy with the use of tubectomy, and we compared country rankings that the UN compiles on gender inequality with rankings of vasectomy prevalence that we compiled, and we'll see that momentarily. Next slide, please. Vasectomy is one of only 2 contraceptive methods for men, and it's one of only 2 permanent methods. It has long faced deep-seated myths and misconceptions among men, women, and providers alike, and provider bias against it is widespread, so that despite many positive features, demand for it has always been low in low and middle income countries, though in all countries there are at least some men who have taken vasectomy. Next slide. These were some of our key findings, and we asked earlier about what is surprising, and we ourselves were surprised and a little disheartened to find that the number of vasectomy users in the world has declined 61% the past 20 years, and it's not even half of what it was 40 years ago. Only 20 of 197 countries or regions in the world have a vasectomy prevalence of 1% or higher. I mean, 1 in 100 women are of reproductive age are relying on a partner's vasectomy. In almost all low and middle income countries, with a few exceptions, it's always been negligible. Only 1 in 1,000 women or fewer relying on it. And as we will show in a moment, countries with the highest gender equality are among those countries with the highest vasectomy prevalence, and vice versa. Next slide, please. This shows you what I was just saying, trends over the last 4 decades. There's slightly fewer than 800 million contraceptive users in the world. And you can see that tubectomy, female permanent method use, has steadily been over 200 million in the last 2 decades. And meanwhile, vasectomy has fallen, even though the world's population has more than doubled. Contraceptive use in general has gone up markedly in almost all countries, and the desired family size has gotten smaller. So, and this is a ratio now of about 13 to 1, but in some regions and countries, the disparity between male and female use of permanent methods is even greater. For example, India has a ratio of 76:1. Next slide, please. This slide illustrates the correspondence of high vasectomy prevalence with high gender equality. In the fourth column, we've rank ordered vasectomy prevalence among 176 countries, and these are the top 10. And South Korea has the highest vasectomy prevalence in the world. 1 out of 6 women there relies on a partner's vasectomy. And among 91 countries that met our criteria, it's the fifth highest. And 3 out of 5 and 8 out of 10 of the highest gender equality countries are in the top 10 vasectomy prevalence. And this would be even more striking, except we had to remove Switzerland, Denmark, Finland, and Norway, which have high gender equality, but have not reported on contraceptive use or method-specific use within the time period we were looking at. And in all of these countries except the US, it's notable that male permanent method use exceeds female. And in those stars, if it's 3 stars, it means it's 3 times as much. And in the US, it's about 11% vasectomy and 11% tubectomy. Next slide, please. So in our study, we had a number of recommendations. I've picked out a few that are the most salient for today. It's very important to have vasectomy champions at all levels: policy, program, provider, community, donor, and that includes men who've had a vasectomy and are willing to discuss it with other men in their community. It's important. We have not generally had the funding to have consistent demand side work, including focusing on women as well as men, addressing gender constraints, and trying to address all the widespread myths and misconceptions about it. We've heard earlier about the value and importance of the many communication channels. Those can be harnessed to increase accurate knowledge, to link clients to providers, and to ensure quality by promoting better follow-up and side effects management. And finally, a male-specific effort, either vasectomy-specific or a broader male reproductive health project, is really what's needed. So thank you, and back to you, Peter.
Thank you so much, Roy. Roy is a consultant for Momentum Safe Surgery and Family Planning and Obstetrics. And as you've seen, is presented important stuff. Now we are going to get back to all the panelists into a discussion. So panelists, please, if you can come on screen. I have a number of questions for all panelists that I'm excited for them to speak to. But also audience members, if you have any questions that you would like to ask them or to reflect on, please add them to the Q&A tab. And for the panelists, there have been a number of questions in the Q&A. Please look at the questions, and if there is one that you can answer, please answer it in the chat. I'm going to start with Aisha, and we are going to be a bit summarized because of time. Depending on the type of programming for men can be engaged as supportive partners. They can be direct service users or caregivers in the case of child nutrition or immunization. What consideration did your team make to determine how best to engage men given their role in your project type of programming? Can you share an example that helps to illustrate this? Kenny, then later a related question for Roy.
Okay,
thank you.
Thank you, Peter. Yeah.
Let's start with Aisha, sorry. Then we get to Kenny. Yeah, sorry.
Thank you so much for that question. So basically what we did, as I mentioned earlier, was we conducted a very comprehensive research where we tried to gather insights from men and try to understand what their needs were, what their interests were, how they felt about this topic, and where they felt things or information was lacking. So once we understood their needs, understood their interests, understood their side of challenges as well, which included, a wide range of them feeling ashamed of getting this information from the right resources, having, feeling judgmental when they reached out to service providers because most of them are females. Once we understood all of these, we specifically geared our communication addressing those insights. And like I said, to give you an example, the chatbot was one of the results of the research that came out, because we understood that men wanted something that was private, that was something where there was no judgment involved, where they could get information in one place at a time, which was more convenient to them. And mobile penetration, like I said, is higher, so they felt that they could use it at a time and in an environment where they were more receptive to the information. So chatbot in itself is an example, and that's how we approached it.
Thank you so much, Aisha. Kenyi, the application in South Sudan.
Okay, thank you, Peter. Yes. Hope you're getting me.
Yes, I can.
Yes, as I mentioned earlier on that we conducted social norms assessment in the country, and one of the recommendations was that given male domination in family planning decisions making, and the emphasis was to create this innovative male engagement strategy that can be able to bring men on board, bring men and boys on board, men and boys especially, and then make them as partners for an who can be able to help advocate and promote issues related to sexual reproductive health services. For example, including things to do with the modern contraceptives, to address age of marriage, for example, in relation to marriage of young girls, and also the importance of sending girls to school. So the male engagement program is what we in fact discuss, and this is the outcome of what we decided to have. Thank you.
Thank you so much, Kenyi. And Roy, what ought teams consider when engaging men as family planning users?
I mentioned a few, but I would repeat that couple, and we've heard the importance of couple counseling, the importance of satisfied clients being able to talk to men, being able to speak to them. On average, a couple takes about 2 years from considering a vasectomy to adopting it. So the demand side is important because the service side is never going to be very fast until all the myths and misconceptions are addressed. But male-friendly services are an important way to try to do this. You could have workplace services or hours that accommodate men who work and otherwise can't get to a clinic. Those are a few thoughts. I know we don't have a lot of time for more expensive.
Thank you so much.
Yeah.
Thank you so much, Roy. I'll now get to Rosalind, Nady, and again, Roy, if time allows. When engaging men in the various types of health programming, how can we ensure that both men and women partners experience high quality care? This has also been a question by Dr. Mongerera in the chat. Rosalind.
OK. Merci beaucoup. Je vais vous...
Thank you very much. I'm going to share the experience from my MCGL project in Côte d'Ivoire, where we try to ensure that men and women have access to high quality care. And it's important to understand the needs and the preferences, whether it's of men or women, in terms of high quality care, because often we find that in communities, both rural and urban, and especially in rural communities, that each community has its own specific perceptions of what high quality care is based on their cultural and social norms, but also based on international and national healthcare norms. So it's important to take that into account. And then with MCGL Côte d'Ivoire, we have an aspect that's focused on the clinic work, and at the clinics, we work with providers to strengthen their capacities to provide high quality care, because we want to make sure that it's respectful care, and we work with them to make sure that they take this into account. And then at the community level, we have also set up a community accountability mechanism that helps reinforce the voice of communities to have access to quality care, so that they can give feedback about the quality of the care they've received, and that this feedback can be taken into account. So it's a mechanism that's like a suggestion box that we set up in the communities. And when they go to a health clinic or when they go back to the community, then they can give their opinion about the service that they received. And then based on everything that comes out of this feedback, we analyze the feedback and see if there are any problems. And then we have dialogues with communities and see if they can organize a dialogue between the healthcare providers and the communities to see how they can set up an action plan to find solutions to some of these problems that were flagged and improve the quality of services. Thank you.
Thank you so much, Rosalind. Nady?
Thank you. For us here, we really feel that the men need to feel that they matter, that their needs are met, and that they are part of the system. We feel that their voice, they need to feel that they have a voice in how the services are carried out. We also look at this. As the question really looks at both the demand and the supply side. So from our side, we think men and women should know their rights. They should know their rights and what to expect from the system. We can also, for example, they need to know the hours of when the health facilities are open, when the services are being given. They also need to know what they should bring through the health facilities, be it the vaccination card or any other thing they need to bring to the health facility. As well, they need to have sufficient level of knowledge on knowledge or literacy on vaccination, on immunization itself. On the supply side, a core principle from the immunization agenda for 2020 is people-centered. So we're really working on encouraging to meet the needs of people being served and the health workers as well. So yes, this is what I have from my side as a response. Thank you.
Thank you so much, Nady. Roy, your comment, how do you ensure there is quality? Yes, go ahead, please.
That clients are not unduly influenced by a provider or someone else, but they're choosing the method freely. Linking vasectomy to other male reproductive health needs is another way to augment their general quality of health care. And again, the importance of champions, not trying to train everybody in a country, but to support the people the providers and service systems that have already shown they're committed to quality and are delivering good services. And in every country, we know where the good services can be accessed and where they aren't so good. And we need to emulate and model the good quality. Thank you.
Thank you so much, Roy. And before you go, Roy, what were some of the unintended consequences that you encountered in your work? This could be positive or negative. And how did you address them?
Well, one unintended consequence I still remember, and from a while ago, but it's a lesson still relevant today, is there was a communication campaign to promote male responsibility, and the message was family planning, it's your choice. And it became understood that the men should choose, only the men should choose. So that was inadvertent, but again, underscoring the importance of open communication between couples and free voluntary choice by any family planning client.
Thank you. Nady, did you have any unintended consequences?
Thank you. Yes, we did. And one of the unintended consequences which had really to do with having men taking the child to the health facility. It is okay for us, yes, but it's not really what we intended, having the men take the child to the health facility. So we see this as an unintended consequence because there is a lot more that we are expecting from men. We had what we had was really the men taking the child to the health facilities, whilst we do not have spaces designated for men at the health facilities. And I did see a question in the chat whether somebody asked about whether we were giving any incentives to men for them to take the child to the health facility. No, we did not, and we are not giving any incentive to men to take the child to the health facilities in Mozambique. But through community mobilization and the work we are doing at community level, we did see that the men did uptake this. They're interested and they're willing to do this, and they were all taking the children to the health facility because of the work that was done. So this was unintended, really, because it's not the response that we wanted. It's okay, but that's not really what we expected. There's a lot more to male involvement than carrying the child to the health facility. Thank you.
Thank you so much, Rosie. And then any unintended consequences, positive or negative?
Oui, au niveau du
Yes, with the project, when we started implementing it last year, and the activities for communications with the couples, one of the unexpected consequences that we saw was that given the message that we were conveying, we started to realize that the message, often the facilitators of these activities, were strengthening somehow the power of men by trying to engage more men. To give you an example, we would say men need to support their wives, or they need to help their wives or accompany their wives when they go to the healthcare services. And what we weren't focusing enough on were the preferences or the needs of the women. We wanted the men to be involved, but we weren't really focusing on what type of help they should provide. Or we were kind of strengthening their power by saying it, implying maybe that the men needed to take the decision, or that they had to be the one to take the woman to the hospital or the health clinic. So we had to work with the facilitators to sort of revamp the message so it didn't have this negative consequence and unexpected consequence of reinforcing male power.
Thank you so much for that. I have another question. I see Rosalind speaking, but it seems you're on mute. Are you saying something?
Peter, can you hear me?
Yes, I can.
Yeah, since I gave an example that was maybe negative, a positive example I can give, and the importance of champions. In Brazil, I was with the leading vasectomist in the country who had established an organization devoted to male reproductive health. And we were walking along a beach front, and 15 men in Brazil came up to him and said he had done their vasectomy. And so in a country that's known for machismo, and you wouldn't think men would be adopting the method, Brazil now has almost a 5% prevalence of vasectomy. So it again illustrates the importance of champions and charismatic, committed service providers and program leaders. Thank you.
Thank you so much, champions and charismatic leaders. are important. We're going to have another question to Ayesha, Rosalind, and Kenya. How can those implementing male engagement programs better partner with and reach youth and vulnerable or marginalized populations? How do you see intersectionality playing a role in collaborating with these groups? So if for Rosalind, you could comment, how can we reach these vulnerable groups and the youth?
Déjà.
Rosalind? Aisha first, then
Okay.
Rosalind.
Merci.
Okay, thank you. Yes, thank you.
Monsieur le modérateur.
Thank you.
Okay, go ahead.
Yes, thank you very much.
Je vais partager un peu
I would like to
l'expérience
share the
de
experience
projet.
of my project.
Quand nous avons commencé au
When we
niveau de
started
nos
with our activities here, the context in terms of adolescents and youth here is that in the rural areas, there really wasn't a safe space for them, that for young and people and adolescents not in school to be able to talk about or share their experiences and talk about maternal health, family planning, and reproductive health. When we were in the urban areas, there were spaces that were available for them, especially youth and adolescent centers. But these were centers primarily for unschooled adolescents and young, or rather schooled adolescents, but those who were not in school really weren't comfortable going to these centers and participating in the activities or talking with their peers who actually were still in school. So we saw that with communication, we saw the same challenges with couples, young couples, because they weren't comfortable participating in these programs, even if there were spaces where there were adult leaders. So we tried to look at different factors, age, for example, and the level of education. And then based on that, what do? We created new specific activities for this target group of youth and adolescents who were in school by setting up what we call the Future Husbands School and working on other activities where we could provide safe spaces for them to be able to discuss these issues and to discuss their needs with other youth. Thank you.
Thank you so much, Rosalind. Aisha?
Sure, thank you. So I think one of the most important thing in this is to really see where are we starting our conversations from. And one learning that we had was that we needed to start with young people more from a design thinking perspective with that context and lens in mind, because we don't understand this population. This population is very different. They have not been catered to for the last many decades in a country like Pakistan. So it's very important that we use design thinking approaches to understand them first, and then see how innovative ideas can be, brought in. Things like gamification. We have very recently had a very big game jam in two cities of the largest provinces, two provinces of Pakistan as well. The idea was to bring in young people so that they can come up with ideas on how gamification can help this messaging go beyond. And one of the things that I was very fascinated about was on day one of the game jam, I was called in by the players where I was by the organizers, where I was told that young people who were participating said, "Who has come up with this taboo topic? Who has come up with this most difficult topic? We don't know how to gamify this." And towards the end of day two, not only were they able to gamify it, but also they were boys and girls sitting together, coming up with topic, really creating games out of this topic that they thought was taboo. And the winner of our game jam was brother and sister, which is a huge thing in a country like Pakistan, where sexual reproductive health, family planning game by young people was being developed, and that too were brother and sister sitting together and doing it. So I think it's very important that from a youth perspective, we try to take a step back and understand how youth processes things. That's one thing. The other, for a marginalized population, like I mentioned earlier, we have developed training curriculums for government where they have social male mobilizers whose mandate is to work in rural communities where government services are hardly provided, or where healthcare is not very easily accessible. So training that cadet, we initially faced a lot of challenges over there also, because these men did not want to go community to community and talk about family planning and SRH topics. But as soon as we started, sort of gamifying it, making it into a competition, etc., we saw that interest, was gained by these social male mobilizers who go to these rural communities. And they, in turn, expressed that rural communities are also receiving this information much more openly than we had originally anticipated. So one of the key message here is that we need to be pushing the boundaries a little, and we need to also understand, I mean, from Pakistan perspective, what we have learned is there is a far more receptibility of male engagement on this, family planning and SRH, as opposed to what we think would be.
Thank you so much, Aisha. So for participants, if you have a question, we see some of you putting up your hands. Please, if you can go to the Q&A and type your question there so that the panelists can answer. And for panelists, please, and those involved in the program, the number of questions from participants in the Q&A, please, if you could respond to them. I'm going to be pulling in some questions from the Q&A, but let me ask this last question to the panelists before I go there, because it's quite important. If I can get one or two panelists answering, what are some of the consideration program designers and implementers should keep in mind, or best practices for engaging men without compromising or limiting women's autonomy? So how can we engage men and without limiting women's autonomy? Anybody wants to go? Maybe Aisha, you can start, and somebody else, one more person. Yeah.
Sure. So, sorry, I was just typing a response on the chat. So I think I think I sort of alluded to this on the in my previous answer as well. There are a lot of misconceptions related to how men perceive this topic, how men see SI and how men see family planning. As I shared earlier, we did an extensive research and start, and one of the things that we learned in our research was when we did a consumer insight study with women, we got to know that they felt that our partners, our husbands wanted 4 children, and that's why they were having more children, one after the other. But when we spoke to men, they said, we don't want to have more children either. There are economic, the country is going through an economic crisis. There is a lot of inflation. There's a lot of costs associated to all of this. We don't want more children, but society expects us, and our manhood is somewhat linked to having more children. So we understood. I think we what we did was we took a step back and we sort of empathized with men, and we felt that here there was a woman who wanted a supportive partner, and here we have men who want to support their partners as well, but just don't have the means to provide support. So this was one of the misconceptions that we sort of identified. Some misconceptions that we also identified were that more of the issues related to, or misconceptions or side effects, manageable side effects that persist in the community were coming from men. Men felt that these products have more side effects, and no one was addressing their concern. No one was addressing and telling them what this sort of really means. So what we understood, in short, was that there is no one size fit all. You have to have a sort of a segmentation within your target group of men as well. Your urban men is different from your rural men. Your different economic strata, different education are different, have different needs, and you need to have customized approaches for those. And misconceptions that are related to this need to be tackled head on.
Thank you so much. Maybe one more presenter. Any comment on the question of how do you ensure women maintain the autonomous engagement? Rosalind?
Okay, thank you so much. Along the same lines as what Aisha was just saying, I would say that it's important for program leaders and implementers to ensure that male engagement isn't discriminatory against women or doesn't contribute to marginalizing women. Our programs need to engage women, or men rather, in such a way that we still keep the priority on women. And let me give you an example. Perhaps in a project, we might want to look at a certain behavior, and this behavior might be that men should be supportive of their partners when they go for their prenatal visits. And on the basis of this behavior, maybe there be some providers who have the attitude that they should put the priority over women who come to the consultation with their partner. But when we look at this could be discriminatory towards the women who are alone or who don't have a partner to accompany them, and that could marginalize them further. So we have to make sure that these programs seeking to increase male engagement don't create more discrimination for women, and that we still continue to focus on women and take their needs and their preferences into account. We need to make sure that we understand that women do want men to be involved, and we need to continue to have male engagement, but we have to still promote women's autonomy. Thank you.
Okay, thank you so much. There are a few questions from, not a few, actually quite many questions from participants, and thank you for raising these questions. I hope panelists you respond to them, but I'm going to read out a few. One is a question from Diallo, and Diallo was asking, the percentage of client satisfaction was 49. What is the reason behind this? I think that was from our first presentation. Then we have a question from Florine, and Florine was asking, please, Nady, how do you address social norms, knowing that there are influencers in the we seek traditional rulers? How do you ensure that you address social norms? There is also a question from Florine. And Florine, how do you, Florine was asking that one of social norms. And there is a question from Sonali. Sonali is asking the question, how far are provider skills in engaging with men impacting the program? So if somebody could comment on that. Of course, panelists, you could answer any question that has been asked to you that you think you need to respond to. So let me have the panelists. Maybe could I start from those I see? Roy, do you have any question you would like to answer?
For me to answer in French, but I see there's a question from Mali about whether vasectomy would be appropriate in Mali and I guess by extension, West Africa. And it is in that if we don't lay the ground and make it a normal choice, it will never be one. And there are men in every country who will adopt it even now. You would not expect a lot of men to be adopting it, and men and women have fears about what effect it might have on the man's productivity and things like that. But it does not mean that we should not have it on the cafeteria of possible methods, and to be thinking about it, talking about it, and having it in a place like a medical school or a leading facility where it can be seen and known. And I've encountered in every region the misunderstanding that vasectomy is castration. So we need to start, if we don't address this now, I've basically seen it not being addressed the last 20, 30 years, and it will continue to not be a method that is available. And we will be kidding ourselves when we say we have full method choice if we don't make it known and available in all countries. But I would not expect high uptake very soon. Thank you.
Thank you so much, Roy. Kenyi, do you have any question you'd like to respond to briefly?
Yes, I wanted to respond to the question in relation to the provider skill in engaging men. Yes, in relation to this question, which says how far are provider skills in engaging with men impacting programs? Providers are in fact engaging men through the board game. And this board game is basically to be able to create an understanding of male involvement in family planning. As I mentioned earlier on, the board game is literally trying to create scenarios. These scenarios enables men who are playing this game to widen their thinking or think broadly in a way that they are able to look at their context and also relate. And this enables the men who are playing this game to be able to learn new things in relation to family planning. Thank you.
Thank you so much. Could I go to Nady? Another question you want to address?
Yes, thank you, Peter. I would like to address the one on social norms. I did go through a question on social norms, how we go about it, and regarding the social norms at community level in the provinces where we are working, we try and involve the community structures to clarify through community concentrations to clarify about the and why we want we expect men to be also involved, religious leaders, if the norms are related to the religious sects, or if people do not feel like they should get involved because of some religious belief. So we make sure that we involve religious leaders in some in these activities to clarify what is expected. And we have had experience, and we that through religious leaders, if it's the religious leaders talking about the importance of their involvement, then this issue is overcome. Thank you.
Okay, thank you so much. We're running out of time. I just wanted to summarize that what I've learned is that very important to engage men. It is possible to engage men. We need to be very innovative in engaging men. Men may not necessarily be knowledgeable. We need to empower them with that knowledge, and engaging men empowers also women and younger people. But this varies from context to context, and we still need to learn more. I would like to thank you everyone for joining us today, and for panelists for lively discussion. Please take a moment to share some feedback through the survey link in the chat. So a survey link is being put in the chat. If you can provide some feedback on this important topic, we'll share the slides with you by email. And also, I would like to thank you for joining this important webinar. So if we can have the survey link, and if people could provide feedback on that survey link over there. I would like also to thank our panelists, a very able panelist, Roy, Ayesha, Rosalind, Kenyi, and Reshima, and the colleagues at Momentum who actually organized this webinar, did a lot of the planning. Thank you so much. As I said, we'll be getting back to you with these presentations and all the resources that have been referred to in this webinar. Thank you so much, and have a lovely day or a lovely evening. Thank you, and bye-bye.
Thank you, everyone.
Bye.